Hello, everyone, and welcome to today's webinar, Pre-Implementation Activities to Ensure Equity on the HIV Care Continuum. My name is Eduardo Salinas, and I'm the Communications Coordinator for ISKI. We are excited for today's presentation, and I do want to start with some quick housekeeping rules. You will notice that this is set up as a meeting rather than a webinar, as our presenters did want to have the ability to interact with you on a more personal level. We are happy to take your questions and comments, though at this time, everyone should be muted, and we ask that you remain muted unless our presenters ask for your participation. You can always post your thoughts and questions in the chat box, which we will be monitoring throughout this presentation. And we will also, of course, have some time afterwards for any questions, thoughts, and discussion. Now, I do want to introduce our esteemed presenters today. Our first presenter is Dr. Ava Woodward. Dr. Woodward is a clinical health psychologist. In her research, she uses implementation science and practice, community-engaged research, and mixed methods to improve equitable healthcare delivery for groups experiencing disparities, such as people of color, sexual minority, and low-income individuals. She complements her research with clinical care in primary care mental health integration. She is also a trainer for the Implementation Facilitation Training Hub, operated by the Behavioral Health Quality Enhancement Research Initiative through the Veterans Health Administration. She works as a career development awardee at the Veterans Health Administration and as a faculty member at the University of Arkansas for Medical Sciences in Little Rock, Arkansas. Our second presenter today is Dr. Florence Monplaisir. Dr. Monplaisir is an assistant professor at the University of Pennsylvania in the Division of Infectious Diseases, Vice Chief for Equity, Diversity, and Inclusion in Infectious Diseases, and a senior fellow of the Penn Leonard Davis Institute of Health Economics. Her clinical research focuses on improving health outcomes of women living with HIV and on reducing racial disparities in health outcomes. She holds 2 R01 funded projects focused on using lay workers to implement theory-driven behavioral interventions to improve adherence to antiretroviral therapy and engagement in HIV care. She uses mixed methods to understand behavioral and structural factors contributing to racial disparities in HIV outcomes and on implementing clinical programs addressing the sexual and reproductive needs of individuals with HIV across their life course. Now, without further delay, I will let our presenters get to the content. So take it away, Dr. Woodward.
Thank you so much, Eddie. Thank you so much to the group for ISKI for having us here. I know that Dr. Monplaisir and I are excited to kind of start big picture, which is what I'll do, orienting more to kind of paradigms on how to think about implementation and equity, especially in earlier phases of implementation work, because that's where we heard many of you are with your funded projects. And then Dr. Monplaisir has a really wonderful applied example of using these principles in her work. Okay, let me get my screen sharing going on. And I'm going to try to use subtitles on here for it more inclusive for those who need it. Eddie, I need to do a quick check. Are you able to hear me and see me okay?
Yes, we can see your screen as well.
Okay. What this is about. Okay. Okay, so my name is Eva Woodward. Please feel free to call me Eva. I have a background in HIV prevention. That was my original training, and I have loved it. And at some point thought about how we have so many good interventions and treatments and screenings. How can we get them used more? And that really took me to implementation science as a method for our practices that work to have more impact. And especially with a core question for me is, how do we do that in a more equitable and just way? So today I'll be talking a lot about considering an equity lens, more informative evaluation and for HIV implementation research. And a couple of disclosures that none of the views here represent the US government or the VA, and I am a paid consultant for V Healthcare. Follow me on Twitter if you want to engage there. Always interesting stuff going on. First, let's get present. You all are coming from lunch. Maybe you got some childcare or older caregiving going on. You've been teaching, you're in a meeting. So let's just get centered with each other for a moment. I'm going to ask you just to minimize your screen wherever you are. We're going to take about 60 seconds to just do a quick mindful breathing exercise. You weren't given informed consent, but you are with a psychologist right now. So if you are willing and able, we'll go ahead and start that now. You might just want to look at a neutral place on your desktop or the wall. I'm going to close my eyes and just breathe as you normally would. And noticing when you breathe in, maybe even saying to yourself, breathing in, inhaling, noticing where you feel that in your body most intensely. Noticing if it's cold or hot, itchy, smooth. And now also noticing on your exhale, noticing when you're doing it, saying to yourself, breathing out or exhaling. Not trying to change anything significantly, just spending maybe 15 seconds just breathing and centering here together. One more cycle of breath. And now kind of reorienting, fluttering your eyes open if you had them closed, or kind of grounding your hands on your legs or on the desk. Thank you if you did that, and if not, thank you for tolerating that. Just getting here. I want to ask who is here with us today, and I'm going to ask you to annotate. In a moment, I'm going to show a map of the United States and Canada, because I heard we might have some Canadian participants up north. And I'd like you to annotate and mark where you're calling in from. If you've never annotated, you can go to the top of your screen and it will say, you're viewing my screen, view options, and you'll scroll down to annotate. And then you can click on that little draw squiggle or use a stamp, which is very fun. The little checked stamp. You can choose a star or a heart and just stamp where you're calling in from. So that way we can see. So I'd like you to annotate on the screen now. Where are you calling in from today? So just a reminder for instructions, you'll go to the top of the screen and to the right, view options, and scroll down to click annotate. And you can use a stamp, you can draw. I know I couldn't position the Canada really on top of the United States where it needed to go. But this was the best I could do. Okay, we've got some people. Oh, great, New Mexico. I have some great colleagues there. Someone right above me in Missouri. Hello. Right north of me, I'm calling out of Little Rock, Arkansas. I'm seeing a lot of likely Chicago interaction. North Carolina, a lot of great HIV prevention stuff going on there. And we've got some New Englanders, my former home of Providence. I was there before I moved to the VA. Okay. And possibly someone not depicted here, but it is, thank you for that. So we kind of get a graphic representation of where people are. I didn't mark myself, but I'm right there in the middle of Arkansas. Okay, that's a good sense where we're all calling in from, which kind of informs some of our perspectives and some of the, as you look at these places in the US, they have very different societal contexts. They have different laws and policies. They have different industries. that are big. They have different groups of people living there, different migration patterns of people that have left, people that have immigrated to there. And they certainly have different HIV prevalence and incidence rates as well. So that's just to kind of get us in the mindset of thinking about the context where we all are and how that can affect implementing things, because societal context matters. Okay, so let me just start big picture. Oh, except for I probably need to clear that screen. Just a second, everybody. There we go. Okay, let me start big picture with just thinking about how implementation science and equity or health disparities research, those two paradigms, fortunately, follow the same kind of steps, which is detect, understand, and reduce. So in implementation science, we care about detecting a research to practice gap. You have something that's researched, it's shown to be effective, but it's not being used widely or widely enough, or it's not used amongst certain populations that need it. And then you try to understand why that gap exists. You want to diagnose the problem. Why is this going on? And then you want to do something to reduce the gap. In this case, that's developing implementation plans and using strategies to reduce that gap. And fortunately, healthcare disparities research follows the same basic steps, which is detecting disparities in healthcare delivery, figuring out, oh, there are people that are not getting this at the same rate or with the same quality, or if they get the treatment, they don't have the same good outcomes. And we need to understand why that is first. And then we need to reduce it. We need to do something about it. And so you can see that wherever you are, what populations you're studying and health needs they have, you'll have to figure out where they are on the bottom arrow. And then you'll also have to figure out where in the implementation pipeline your particular intervention or practice is, and align your methods accordingly. So if you're doing a study where you are trying to implement something and focus on equity or reducing disparities, you might have methods that are built into maybe understand an implementation gap, but maybe you're still at the detecting disparity phase for that particular population or group. I'm not sure where you all fall, but you should give that some thought, and your methods should align with where the science is in your area. And what's really nice is once they can align, once you're at the same understanding or reducing step with each, you can actually use some of the same methods and data collection and analyses to answer those questions simultaneously. So one basic point of my talk to set up the applied example you'll see soon is using models, theories, and frameworks to inform your diagnostic assessment or your formative evaluation, which then informs the implementation plan where you select strategies. So if you, coming back, if you are understanding the gap in terms of why the disparity is there or why the implementation gap is there, then you need to do a diagnostic assessment, also captured under formative evaluation. And you should use some theoretical model to inform that. So here's an example, because I heard many of you are using this framework, EPIS. So you have a bunch of stuff in the middle that are factors that predict whether implementation will be harder or easier. And the circle on the outside is a process. First you explore, then you prepare, then you implement, and then you try to sustain what you implemented. So these two sections, exploring and preparing, those are also called the pre-implementation phase in some models. So I'm just giving you different words that mean the same thing. So that's the focus area for this talk. Dr. Montplaisir's example that she'll share with you later occurred in that pre-implementation phase or in that exploring and preparing phase. Now, models, theories, and frameworks need to be adapted for healthcare disparity problems or equity problems. This was said, written long ago by a chapter led by the late Dr. Yancey in kind of the blue textbook that's kind of considered to be the textbook in implementation science. And There are many different types of frameworks that can be adapted. I just want to review them. There's kind of three basic types that I think about the most frequently. Determinant frameworks. What are the barriers? These are frameworks that tell you what are going to be the issues here. There are process and planning frameworks, which help you understand how will we achieve this? What's going to be the strategy? What's going to be the plan of attack? And evaluation, going back and asking, how did it go? So you will need at least two of these frameworks in almost every grant. And for R01 level type, you might need all three. So let me go back for a moment to EPIS. EPIS has determinants here in the middle and a process, the blue stuff on the outside. So it's actually a determinant and process planning framework in one. And any of these need to be adapted for healthcare disparity problems. There are a couple of adaptations out there for some frameworks in each of these types, but not a lot. And I will be talking to you more about one of them today. So let me ask where you are with using frameworks in your work. I'd like you to type in the chat. The frameworks I am using or thinking about using are, just to give me a sense of where you're at, what you're using, what kind of tools you're interfacing with, and where some of the needs are for our future discussion here. So type in the chat, the frameworks I am using or thinking about using are. Okay, I'm opening the chat. We have REAIM, an evaluation framework. We have CFER, that is a determinant framework. We have EPIS, which I just explained. Oh, I see Ayaka. Oh, right. My fun buddy that I consult with, and a very smart, thoughtful researcher on health disparities in the criminal justice system. Okay, so using CFER for some determinants and some from the Health Equity Implementation Framework. I'll give one more moment for folks to put in the chat the frameworks you are using or thinking about using. Okay, so there's an adaptation framework. I'm glad this is coming up, and adapt. How did they say it? Adapt ITT or adapt it? I can't remember now. But that one developed by Dr. Wingood is developed in HIV world. So that's makes sense to use. That's a type of framework I did not go over in the past three types, which is when you're adapting an intervention. Okay, great. I'm glad we've got a lot of CFER here because I have an example about that coming up. Okay, so if you are thinking about how to incorporate more equity and focus on disparities in your work with your frameworks, they will need to be adapted to do that. Because the whole idea is if those frameworks if it's not built in, then you likely won't think to collect that data and you likely won't think to capture it. So you'll probably be missing huge determinants in your diagnosis of the problem, of the gap. So one framework that my colleagues and I adapted was to solve that very problem for ourselves in some work we had done on trying to improve implementation of the new antiviral drugs for hepatitis C among Black and African American veterans. So we adapted an existing determinants and process framework, and we added 3 health equity domains, and we call it the Health Equity Implementation Framework. This is our original publication, and I'm going to explain that framework to you now. I'm going to build it out for you here and showcase it just to show you kind of the thinking and what we adapted to make this have an equity focus, what 3 equity domains we added, and then you can consider them for your work. So first part of the framework is the innovation itself. This is the intervention, screening, practice, or program you're trying to implement. This might be ART, this might be HIV testing, this might be PrEP, it might be some other type of psychotherapy to help people adhere to a regimen. And so there's a lot of characteristics you want to know about this determinant, like its relative advantage over other programs or practices and its degree of fit in the setting in which you're trying to implement. There's also a bunch of people involved because implementation is a highly people process. There are recipients at the top, patients or community members or possibly students in your setting. We adapted this framework in a healthcare context, but you might use it in a criminal justice setting, in a school setting, and your recipients will have those different titles. But you want to know, what are their beliefs and preferences? What are some of their culturally relevant factors, such as health literacy, their past lived experience that then affects their needs and attitudes. And at the bottom, you have a recipient that's a provider. It might be a lay health worker, community health worker. It's a person who then would be offering something to someone. And similarly, you want to know their characteristics as well, their beliefs and preferences, knowledge and attitudes, competing demands, bias they might have about the health issue you're working on, such as drug abuse or HIV. Perhaps it's bias, based in racism or transphobia that you want to be aware of. And then you might also have other recipients on the left. Maybe you're in settings where there's some type of administrator or middle person, or perhaps front desk staff that the patients or end users will interface with. And you also want to know, what are some of their culturally relevant factors to your particular implementation effort? So our first adaptation we made was signaled by this black star. We added culturally relevant factors to all of the people, really examining their lived experience and their social characteristics that then inform how they see the world. And then there's a moment when they all come together. This was the second adaptation we made. We call it the clinical encounter. You might call it an implementation encounter. This is the moment when you want the end user, patient, service user, student, whoever, to come together with some type of provider for them to offer something. Do you want to do this testing? Do you want to enroll in this therapy program? Do you want to try PrEP? And then you hope that that person says yes. But we all know from healthcare disparities research that what happens in that moment, that encounter, is really predictive of whether people will accept. It's predictive of their satisfaction. It's predictive of their trust. It's predictive of their health behaviors and outcomes. So things in the clinical encounter are what actual behaviors are occurring between these people. And then all these people and innovations are nested in a context. So I think about this at the local level. That might be like a very specific unit, like a classroom or ward or service. And then there's also the organizational level. Maybe that's within a department, a broader place where you are trying to implement. And they can all be nested within an outer healthcare system or a school system or a whole regional set of jails, for example. But you also have these outer contexts that you want to know a lot of factors at those levels that you get with CFR, for example, asking you, what's the climate and culture of these with implementation support and change? Is there leadership support for this? But you also want to be asking, do they have any experience addressing disparities or equity problems? And how did that go? And all of these are nested within a very big societal context, which was our third main adaptation. And these are factors that can have a direct impact on the people and places within it, but it also could be downstream effects. So these factors are economies, finances. How is the innovation you're offering? What has to be exchanged to get that financially, insurance-wise, cost-wise? What are the physical structures that people have to navigate to get to the quote unquote point of care? And this is the built environment. What about, how they get out of where they're staying, public transit? What do they see at the point of care? What signage do they have? Are the signs in a culturally or linguistically appropriate level for them? Who answers the phone when they call, and what languages do they speak? And do they speak in a way that is accessible to those individuals? If you're doing a technological intervention, something with digital health, is there enough broadband? Do people have computers? These physical built environment structures. And then there's the socio-political forces. These are social norms that might be present there, such as structural racism. It could be transphobia that could be affecting what's going on. It could be policies or laws, policies, don't ask, don't tell. In the military, it could be policies around, can we offer, gender affirming care? It could be laws that are going on, or entire mass movements, such as Black Lives Matter, or really increased ICE detention rates that seem so big picture, you can't ever imagine them being relevant to your project. But if you've been working in this field, they trickle down to the people and the places in these inner circles, and they matter for implementation and equity. So this is the health equity implementation framework. The 3 starred areas are the adapted 3 health equity domains we added to this existing implementation framework to use. And we also propose that you have to have a process to then address the determinants. Some determinants are going to be helpers, facilitators. Some are going to be barriers, harmers for your effort, but you're going to need facilitation or other strategies to enact change. And hopefully then you'll assess with your evaluation frameworks 2 different outcomes: implementation success and improvements in equity. So let me break these 3 domains down a little bit more. My biggest piece of advice, one takeaway, is with all of y'all who are using the CFR for sure, EPIS determinants, assess 3 health equity determinants in any implementation effort if you're focused on a group that is experiencing marginalization. Again, those 3 determinants are listed here: culturally relevant factors of all the people, the clinical encounter, and societal context. So we just published last year a more practical guide to incorporating those domains into any implementation determinant framework. You cannot easily add these to an evaluation framework like REAIM, but in fact, there's some publications out that starting to do that for you, which I could put in the chat later. So let's take a dive into each. I'm going to show you each determinant on the left and some sample methods and measures. And these are samples from that paper we published last year. You can see a more exhaustive review in that table. Societal context, remember, these are economies, physical structures, socio-political forces. It could be social determinants of health at the aggregate level. Here's some sample measures and methods on the right. I'll just name a couple. You might look at insurance claims data of that group. How are most people insured here? You might do some ethnographic observation of physical structures. Like our friends in public health, you might do windshield surveys or walking surveys to look at these structures. You might do some document review, which is a particular method of written policies and in those organizations. There's many things you can draw from that are already out there. The second determinant, culturally relevant factors of the people, the recipients. Here's some examples on the left. Is there a demographic match between the person you're having provide this care and the person you want receiving it? Is there any bias among those groups? Is there mistrust among the service user group? And to get at that, you might do things like administer the medical mistrust index. You might administer the health literacy scale. If you're not familiar, the Phoenix toolkit here is a whole list of suggested measures from NIH about measuring social characteristics that you can go to. You might end up doing some qualitative interviews to assess what important beliefs and attitudes are. And then the final determinant, that clinical encounter, this is requires some specialty knowledge and training, and you might need to bring somebody in to do this, or do your best with something you know. You could do something more intensive like audio record encounters, or ask those people to do fidelity checklists, or observe a sample of the encounters with someone on your team, or debrief and interview the patient's providers or health workers and service users afterward to see what happened and how that communication went. So there's just some sample methods and measures that you could use there, and hopefully could be incorporated and added on when you are doing your diagnostic assessment. So now I'd like to step back for a second I'm going to show you an example in just a moment about how we used some of these 3 health equity determinants with CFER in a diagnostic assessment that we did. But first, I want to just ask in the chat for a moment to help me kind of figure out where to go. The hardest thing you are struggling with related to having an equity focus on this implementation study you're preparing is. So I'd like to ask you to pull up the chat and fill in the blank here. The hardest thing I am struggling with related to having an equity focus on this implementation study is, because I realize I just threw a lot at you, big picture and then some specific stuff, but there's also a lot of stuff we haven't talked about that, you know, I'm happy to, in the chat or verbally in a moment, discuss or share. Okay, so everybody get your responses ready when you're thinking. The hardest thing I am struggling with related to having an equity focus on my implementation study is. So we've got 2 responses so far in the chat. And they both have to do with data collection, having measures that are really important. And this next response coming in is all about measurement. So I'm reading something, one theme, measuring things that are sometimes hard to grasp. You know, I always think about discrimination and oppression sometimes is super visible and countable and documentable, but sometimes it's like smoke. You know it's there, you can smell it, you can see it, but you can't quite grasp it. It's very, very hard in research to really grasp that kind of stuff. And clearly, I hope you feel validated that you're not the only one struggling with it. And then when drawing from routinely collected data, equity characteristics are often not measured. For example, most electronic medical records in healthcare systems don't capture sexual orientation. Absolutely. So you're just like, am I reaching, reach and re-aim, the number one thing. You're wondering, am I actually even reaching the people I want to reach? Wow. The health systems that attend to measuring characteristics that can inform equity may not represent implementers across the board. Absolutely. What's interesting is a lot of implementation science and resources tend to be given to places that can give a little bit of personnel time, have some better infrastructure. And so we end up implementing in places that are higher resourced. And so, the rich keep getting on richer. Not that those service users don't deserve good healthcare, they absolutely do. But then they're not always representative of some health systems struggling here. And talking about measuring intersectionality. Oh, that's very interesting. And someone saying they're using mixed methods, which is very, very important, I find, when you are trying to measure things. Although there are, current measures for stigma and bias out there. We generated a couple of ideas. It's not totally exhaustive in our 2021 paper, the more practical review. This is really helpful. As you keep having thoughts come up as to how this applies to you, feel free to drop them in the chat there, and we'll try to bring them in. Okay, I am going to transition to showing you a brief example of how we added these 3 health equity domains to CFER 1.0 and used it. Now, if you are following CFER, you know that they are on 2.0. They have version 2.0 now. I don't think that's actually, well, someone might have to tell me in the chat. go check on the chat on the CFR.org or CFRguide.org. Is CFR 2.0 on their website yet? 6 weeks ago, it was not. But they have CFR 2.0 that they have evolved, and they explicitly said they've expanded their areas in many domains, which do account for some more focus on equity and marginalized populations. But equity and disparities is still not an explicit focus in their work. And the developers have said, wow, it would be great if people using CFR would take these 3 health equity domains and add them. But I prepared a slide I'm about to show you comparing CFR 2.0, some of the changes they made in their domains, to some of the domains from the health equity implementation framework to show that there's already a lot of overlap there. So if you have the ability to shift to using CFR 2.0 in your work at this moment, and you might not, it would capture a lot. So let's take a look. CFR 2.0 on the left, these are not all their domains. That's just some of the domains they changed in the 1 to 2.0 revision, and the health equity implementation framework on the right. And you can see there's a lot of alignment. Like, for example, at the top 2, they changed their inner setting to have some more structural characteristics focused on physical layouts. And that's represented in the health equity implementation framework with physical structures. In the inner setting, they focused on recipient centeredness, which could be captured with culturally relevant factors of recipients. You can see they have many outer setting things they've also incorporated. Socio-ecological characteristics, like what's sort of when we did our annotation at the beginning to see where we all were, and I noted we're all coming from different contexts, taking a snapshot of the place where you are trying to implement is important. What mass disruptions, i.e. a COVID-19 pandemic, have happened recently? And so on and so forth down the list. You can see there's a lot of alignment there with the health equity implementation framework. And yet, the health equity implementation framework focuses more deeply on equity in the clinical interaction or the implementation encounter, and has more breadth throughout their determinants that are focused on equity. So if you can move to CFR 2.0, you're going to be capturing more equitable areas to measure that will force you and your team to really figure out, how are we going to assess this? Interviews, how are we going to measure this? Or maybe we don't have the capacity to, and we just need to know that and mark that and be aware of that. So you can take the 3 health equity domains and add them to CFR 1.0. And I want to share with you a brief applied example. So this was an ongoing study, not led by me, but led by my colleague, Dr. Sonia Singh, out of the VA in Little Rock, Arkansas. But I consulted with her on this and helped her design the interview guide and helped her process some of the qualitative data she got. So this is an ongoing study, and the study aimed briefly, this was not HIV prevention, but it was to document healthcare provider understanding and veteran experience. So those are the patients in our healthcare system, veterans, of LGBTQ plus affirming care. So the VA has rolled out a lot of affirming care guidelines for sexual minority and gender minority people, veterans that we serve, for years. And we've been doing a lot structurally, policy-wise, and trying to help providers in that clinical encounter do things differently. And so at this moment in time, Dr. Singh wanted to identify what's the provider understanding and the patient understanding of affirming care at this moment in these 2 groups. So what's the innovation? Affirming care policies for LGBTQ plus veterans. Who are the recipients? There are the veterans themselves, but then you have these other recipients that are these implementers. Each site has that LGBTQ plus veteran care coordinator, and then they have the actual healthcare providers and staff delivering all kinds of care. What's the inner setting, to use CFR's language, or maybe the inner context, to use my language? We assess this in 2 large hospitals and 1 rural satellite clinic in the South. What's the outer setting? 2 US southern states in the VA. Okay, so that's kind of where we are, who's involved, and what the innovation we're trying to assess. We're trying to diagnose and understand gaps in implementation. So briefly, recruitments and methods that she designed. She had 8 veteran care coordinators. She interviewed 10 providers and 9 sexual and gender minority veterans. Did qualitative interviews and used a rapid kind of data categorization tool called template analysis to reduce the data. And then here were the questions that we designed to ask about CFR inner setting and outer setting domains and the 3 health equity domains. So she asked about inner setting and outer setting, just like CFR normally suggests you do. But then here are the 3 domains on the left that are about health equity that she incorporated. Culturally relevant factors of recipients. Do you have a general sense of the last provider you saw and their beliefs related to LGBTQ plus veterans? What do you believe are unique health needs of yourself or someone else who's LGBTQ plus? Then the clinical encounter, you can see she asked 4 questions about that because it's like smoke. It's hard to grasp. You know something's going on there. You can smell it and you can see it, but it's hard to grasp. Are there any providers or staff you interact with who you feel like are very affirming? What exactly do they do to make you feel this way? What could providers or staff do to make you feel more comfortable? And then the societal context. So she just asked this one question at the bottom. Can you think of any factors outside of the VA system that might impact the care you receive as a, insert identity, LGBTQ plus veteran? So you can see these are some questions we designed. And in one of the second publication I mentioned that we put out last year, we have an interview guide posted there and a code book, a qualitative code book actually, that you can use. And in fact, our qualitative code book from the Health Equity Implementation Framework, we designed it to match the formatting of CFR so that they could be easily combined in Excel. So, okay, let's see what we learned. We learned that there were some challenges and some value added to integrating CFR in the 3 health equity domains. You can use CFR 2.0 on its own, or you could use the Health Equity Implementation Framework on their own as determinant frameworks. However, if you want to focus on equity, you might include those 3 equity domains with CFR 2.0 or 1.0. It's fine. One challenge we had was that there was a lot of overlap between CFR and the Health Equity Implementation Framework questions that led to a lot of duplicate questions. But when we just did pilots, kind of with mock participants, we were able to identify those and minimize them. So big learning lessons here, 2 or 3 learning lessons. To the societal factor question, that one question, people brought up laws, they brought up presidential administrations, they brought up harassment, and it really ensured that there was a focus on these systemic elements and how they manifested in interpersonal experiences for people, so that we didn't divorce what was happening between 2 people from the rest of the system that created it. So here's a quote about social norms and experiences with discrimination. LGBT members were afraid of what they would face in the VA. This is from a provider, I still feel that a lot of them don't come out, don't get help because of the fear of how the structure is and how it fits with them, and they feel rejected. They feel isolated. Some of them live in fear of being hurt. At one time or another, they were mistreated. But I think if somebody doesn't like them, they'll wait for them to corner them, if you know what I mean. I don't want to say the staff is going to do it. A veteran could do it. But if you look at it in society, there's been a lot of violence toward LGBT. That does not exclude veterans in the VA system. And I'm not talking staff, I'm talking other veterans who still feel threatened by LGBT people. So that's structural stuff that's showing up in their day-to-day lives and their healthcare. Another overall thing they learned from combining these domains and interviewing them for a diagnostic assessment, there was something really unique about adding those domains. With the clinical encounter questions, we would not have gotten that information otherwise. So look at this. The inner settings were shifting, and as that was happening, affirming relationships with providers were being noted. So these were patients who said, I wouldn't trade my providers for nothing. They're absolutely fantastic. They don't criticize me. They treat me like one of the girls. They ask what my needs are, and 99% of the time they try to comply. This is from a trans client. This other person said they respect what you're called. In the clinics, it's pretty common. They have a lot of trans people there. And in fact, my last doctor was a trans woman. So it made it easier because she understood. So as you're seeing these inner settings shift, these people are talking about that their relationships with their providers are becoming more affirming. And of course, we detected some problems with the clinical encounters, but we wouldn't have gotten that info otherwise. It didn't come up anywhere else in the interviews. And finally, health equity questions encouraged people to deepen into the humanness of implementation. Participants discussed interactions with a lot more nuance. They dove a lot deeper into the factors about relationships that only become explicit when you talk about interpersonal interactions. Implementation, yes, is about all these factors in the outer setting, in the inner setting, in the structures, but it's also deeply about interpersonal relationships and what happens. And we captured a lot of that. So for example, we captured culturally relevant factors among providers that they're really committed to quality care, many of them. One of them said, anything I can do to help out with this particular population has personal meaning for me. It's a good thing to provide care to people who for a long time have not gotten the care that they need. Another provider said, I try to emphasize this has a real risk for the veteran. Our goal here is to serve all. So because LGBTQ plus people are at risk, we need to make sure we understand their perspectives and their experiences in order to provide quality care. So you're starting to see a lot more of what's going on behind people's behaviors or actions or lack of actions, perhaps, and really understanding some of those relational aspects between people. So those were some big lessons learned that Dr. Singh found from combining the 3 health equity domains with CFR. It helped capture some information that wouldn't have been captured otherwise. And also CFR 2.0 does a pretty good job, of capturing some equity focus. Although they acknowledge that it's not as deep as they might like it to be. So if you want to go further, you can incorporate these domains as well. But whatever you're using, whether it's the EPIS determinants, the CFR determinants, the health equity implementation framework, making sure you are using something to inform your assessment of understanding the gap in implementation and equity to promote more equitable HIV prevention care. So that is all for me now. Thank you so much. I wanted to give a shout out to Dr. Singh, and just because part of this was her work. This was a lot of big picture stuff, a lot of stuff to think about. I am happy to, engage in a discussion via chat or in our Q&A in a little bit. I'm happy to answer any questions. For now, I am going to stop sharing and turn this over to Dr. Montplaisir, who is going to share with you a lot more deeply an applied example of doing this work in that pre-implementation phase.
Thank you so much, Eva. And I have to say that what I'm here to talk to you about is really using community health workers to deliver an evidence-based practice called MAPS, which stands for Managed Problem Solving, to improve the HIV care continuum. There's a lot of overlap with themes related to health equity. I have to say that we did not in our work particularly, use or adapt what Dr. Woodward talked about, but I think it helps you to sort of have an applied example of sort of things to think about in your work. So I'm going to just provide some background information around the use of community health workers in general. And if you have worked with peers, community health workers, care coordinators in your work, either clinically or in research, please, add it in the chat. I just want to have an idea of if people in the audience are sort of familiar with working with them. But essentially, community health workers serve as a bridge between the HIV clinic and the overall community, but particularly when focusing on services and healthcare organizations existing within those communities. And they have been really used mostly globally as a pretty consistent workforce, and they're well integrated in the global settings, just because there are a lot of shortages of skilled healthcare providers. However, in the US, it's a different story. But there was a systematic review published in 2013 in the Journal of International AIDS Society, where they measured the impact of using community health workers to improve the HIV care continuum. And their conclusion was that the use of community health workers enhanced the reach, the uptake and quality of HIV services, as well as the dignity quality of life and retention in people living with HIV. And so you can see already the hint toward the mechanism in terms of, trust building and also allowing patients to have dignity and through that process, helping them with self-care behaviors. Now, in general, their role has been pretty broad, ranging from providing social support to particularly focusing on adherence or linkage to care. In the global setting, a lot of them go door to door for direct observation therapy and screening for comorbid conditions. And the mechanism of their success, particularly globally based on the literature, has to do with increasing access to healthcare services, just because they're very well connected. And again, they serve as a bridge, providing social support, which is, as you know, very important for vulnerable populations, increasing self-efficacy and increased involvement in self-care activities. And in addition to this, just particularly in the global setting where physicians or other skilled healthcare workers are very scarce, having someone who is able to address things that a busy clinician doesn't have time to address in a very limited clinical encounter really helps in terms of task shifting and also with reducing cost in general. Now, what do we know about using CHWs to addressing the HIV care continuum, particularly in the US? Well, in high resource countries like the US, the impact of CHWs has been mixed, with some studies showing that they're very helpful, particularly for linkage to care, with others showing that they have no impact at all. And in general, most of the randomized control trials reporting on clinical outcomes were limited either because of short follow-up, small sample size, and also because they targeted very specific groups. So for example, people who inject drugs or people transitioning from hospitalization. And as you can imagine, there's little applicability for the broader group of people living with HIV, which is very diverse, particularly those seeking care in white community-based clinics. And one thing that was shown to be a factor for success or failure was really the turnover of CHWs. In some studies, turnover was really high, which impeded the outcomes. And there's a lot of literature showing the importance of having a well-defined role for this CHW and really having them well integrated in the clinical team because it helps with morale, it helps with work satisfaction, and also addressing the pay has been another issue related to equity that's been mentioned in the literature. So our question was, can CHWs deliver an evidence-based practice focused particularly on ERT adherence to improve viral suppression, particularly among racial and ethnic minority populations, and achieve equity in HIV outcomes? So for this, I'm going to talk a little bit about the evidence-based practice that we're focusing on. It's called MAPS, which stands for Managed Problem Solving. And basically what MAPS is a 5-step iterative process where the interventionalist sits with the client, which is the patient living with HIV, to identify barriers to ART adherence. And then through a shared decision-making process, they brainstorm on potential solutions. They come up with a very specific action plan, which reflects the solution to the barriers that they identified. And then they come up with this implementation plan that, and through a continuous quality improvement process, the CHW follows up with the client and makes changes as necessary for the plan. And in terms of the intervention delivery, the first visit is usually the longest because they get to know each other and also because they have to come up with the action plan. And then there's a series of face-to-face follow-ups and weekly phone calls, and also support with monthly refills. So in a randomized control trial by one of the colleagues I work with, Dr. Gross, MAPS was found to increase ART adherence and also to increase viral suppression up to 1 year after delivery of the intervention. And this is the reference here. It was published in 2013 in JAMA Internal Medicine. And so for this reason, the CDC claimed that MAPS is an evidence-based practice, particularly tailored toward patients who struggle with ART adherence and who are not virally suppressed. And like many evidence-based practices, there's been a real gap between the research findings and actually adopting the intervention in clinical practice. The trial was done in Philadelphia, and even in our setting and nationally, there hasn't really been an uptake of this intervention. And there are a couple of things other than sort of the typical lag that occurs between intervention and development and practice. In the original trial, the interventionalist was a master's level educated individual with a degree in psychology. And as you know, there's a shortage of mental health professionals in the US. And so that might be one of the factors that really limited the dissemination of this intervention. And as obviously, master's level individuals are more costly to the clinic. And so that could have been also another reason for the low adoption. And one other limitation is that the intervention solely focused on adherence to HIV, to ART, antiretroviral therapy, and it was not structured to address retention in HIV care, which obviously is also very important. And so we've done some work to actually addressing those factors, one using the community health worker, but also adapting MAPS to also address retention in HIV care. And the process is really simple, is again, having this one-on-one conversation with client where they problem solve, the CHW serves as the facilitator, and they work with the patient to develop very simple tasks that the patient can implement in their daily life. And through that process, we hope to increase self-efficacy around medication taking so that the client can engage in that desired behavior. And the rationale for using CHWs instead of, again, a master's level trained interventionalist is their ability to develop trusting relationship with the clients. We know, as Eva alluded, there's a lot of racism and discrimination in clinical encounters that's really hard to measure. And there is, even in the HIV workforce, very limited diversity, racial and gender diversity across the clinical workforce. And so having someone who looks like them, who understand their struggles and share similar determinants is important to developing trusting relationships. The need for task shifting in busy clinics, where many healthcare providers obviously address adherence, but they have limited capacity in terms of time to doing so the way that the CHW can do it. And in our conversation with the clinics, we first thought that maybe the case manager would be the best person to be trained in to deliver MAPS. But again, the feedback that we receive is that they're overextended. They have large volumes in terms of caseloads. And so having someone who can really spend that one hour and a half with the client to work on problem solving it felt that it would be an added resource to the clinic. And the other attractive use for CHWs is that they can rapidly be trained and deployed across clinics to reach EHE targets. And obviously, we are interested in measuring cost and seeing if this using a CHW instead of a master's training level interventionalist would reduce cost. So when thinking of the selection criteria for the CHW, this is actually a very important process because again, thinking of the health equity lens, right? Having that trusted relationship where patients feel comfortable disclosing their struggles and problem solving with the CHW is important. So one criteria is that the CHW or the community health worker has to share a basic social and demographic characteristic as the population that they're serving. We're not necessarily requiring that they have lived experience with HIV, but that they reflect the racial and ethnic background of the patient population that they would be serving. And also, you know, for some clinics in particular, it's very important, for example, that they are a part of the LGBTQ plus population. But also just being mindful on the clinic end and also for us as researchers and supervisors of the CHWs, understanding that they are subject to the same determinants as the patients that they're serving. There's been a couple of scenarios already for our CHWs where soon after starting their training, one of our CHWs had her daughter incarcerated and she was committed to the program and still attended training while in court, et cetera. So just again, having flexibility on our end to understand that, you know, the CHWs are subject to the same determinants as the population that they serve, but providing support so that they can be effective at what they do. The second selection criteria for us was that the CHW would need to hold appropriate health beliefs toward HIV care and treatment. And you may think that it's obvious that we don't want to get, you know, people who are biased against or who hold a lot of stigma against HIV or who have a lot of bias regarding race, et cetera. But this is actually a very critical part because there's data, particularly from Philadelphia, showing for PrEP navigators that have been used across the city through the city health department, that those PrEP navigators have very fixed and false beliefs surrounding using PrEP, both in terms of the efficacy of PrEP and also very specific health beliefs around sexual behaviors. And so, and those individuals are linking, you know, patients to PrEP services. And so we felt that we had to be very mindful from the beginning to, for example, use case-based scenarios during our interviews and screening process to understand and assess the CHW's beliefs. And again, you know, hear their reaction and the words that they were using to describing, you know, the clients in those cases to be able to determine if they, you know, to identify those beliefs. Particularly for MAPS, it's important that they have problem solving skills and communication skills. And this is something we emphasize in the training and they receive ongoing training. But because we're testing this in a research study, they are also receiving research training. And again, that's something that we had to, our team had to be flexible around because of low literacy with technology. You know, we've had to really adapt our approach in order to support the CHW and helping them to be successful at their work. And one of the last selection criteria was that they would have to have experience working with marginalized communities. We didn't want to have someone where, you know, who had no prior experience, not necessarily working with people living with HIV, but with a marginalized community, like people with mental health disorders, for example. And the last criteria was that buy-in from the clinics was important. We wanted to make sure that there was a good match between the CHW and the culture and climate of the clinic where they would be embedded. So here we're using CIFER, and again, our intervention is MAPS. The implementation strategies that we're using are task shifting, training plus ongoing support and enhancing communication and integration of the CHW within the clinical team. The implementation outcomes that we're using in our study is reach of the intervention and also cost, and the clinical outcomes are viral suppression and retention in HIV care. And our plan is to roll this out in a step wedge trial. So in summary, MAPS adoption in community clinics has been low. We know that we want to be able to use community health workers to deliver MAPS. And the question is, what is the work that we need to do ahead of time in that pre-implementation phase in order to ensure effective implementation of CHW delivered MAPS? So here we're again using, focusing mostly on determinants and trying to understand barriers and facilitators to MAPS implementation in our clinic. So during this pre-implementation phase, our goal was to understand the multi-level implementation context to maximize the likelihood of MAPS being deployed equitably into those 12 to 13 community-based clinics. And for this, we assess stakeholders' perspectives of barriers and facilitators of CHW delivered MAPS. And this work informed the implementation planning of a type 2 effectiveness implementation trial. So we interviewed a total of 31 stakeholders across those community-based clinics. About 20% were prescribing clinicians. The majority of them were non-prescribing clinical team members, so case managers, social workers, et cetera. Administrators and the health department serve as our primary community partner in this work. So we felt that it was also important to include their voices, particularly as policymakers. So again, we use our qualitative interviews were informed by the CFIR framework. And after each of the interviews, we use a rapid qualitative approach to sort of guide our analysis. So we started with summary sheets that outline the key domains of the interviews. And then the summary sheet content was transferred into matrix displays to streamline the synthesis. And then we use the matrix cells to group determinants of MAPS implementation. And this helped to inform the implementation pathway. And so the determinants of MAP implementations were mapped into main categories along the implementation pathway. And the implementation pathway categories reflected the sequential process of implementing MAPS in the clinic. So this is the MAPS implementation pathway, and I'm going to go through each category and focus on the determinants for each. So the first category is introducing MAPS. And so the stakeholders felt that it was very important that there would be leadership buy-in to promote adoption of MAPS in their setting, but not only leadership buy-in, but that it would be important that there would be buy-in across workers in the clinic. They thought that the messaging around introducing MAPS and introducing the message, the community health worker would be important, that everybody needed to be on board. And particularly having messaging about the CHW being an added resource to the clinic, not a burden, and also educating the entire team on both the CHW role and MAPS to promote understanding of this added value. The second category was integrating the CHW within the team. And so the onboarding process obviously is different for different clinics. Some of the clinics actually identified their CHW themselves, and so the onboarding process was seamless. For some, the CHW were selected by our team, but in a collaborative way and with the buy-in of the clinic, they were integrated into the clinic. And so the onboarding process was a little bit more onerous in that situation. But regardless, the stakeholders felt that training of the CHW and the team would be important just to, again, help with clarifying the workflow and also the clarity of the CHW across the team, because they felt that that would avoid conflicts and confusion particularly because historically most patients and clinical team members see the CHW having a lot of overlap with, in terms of role, with the case manager or the social worker. And so having some role clarity here was really important to the stakeholders. And having a clinic level consultation and supervision for the CHW was important as part of the research team, the MPIs, so Dr. Gross, who developed this intervention, and Dr. Bedas, who's an implementation scientist, and I provide MAP supervision for the CHWs. So we help them with, problem solving activities, et cetera. But because the CHWs have to be integrated in the team, they also need to be supervised by team members. And so it's very important to sort of clarify that supervisory structure. The next category is identifying and referring patients to MAPS. And for that, the clinics felt that, or the stakeholders felt that it would be important to leverage an existing infrastructure where, for example, through QI meetings or data to care, which is a process with the health department to identify patients who are lost to care and sort of generate a lost to care list with the clinics. So again, leveraging those existing resources to having the CHW engage with clients. They also felt that the CHW in some instances could work directly with the provider, particularly with warm handoffs or with specific outreach coordinators to be able to come up with a referral list. A lot of stakeholders felt that having an on-site presence, even again, those interviews were done during COVID, but they felt that both for the integration of the CHW and for the interaction with the client, that it would be important for the CHW to be on site, at least for some of the days. Now, connecting patients and CHWs. So because of limited resources, this is grant funded, and we are working with a lot of clinics. We have one CHW basically go to two different clinics. So each of the clinic get 50% of a CHW. So we spend a lot of time talking about scheduling and being clear on where the CHW should be and when, and being clear about when they would be available. They thought that having a warm handoff, particularly where the provider could sort of bring the CHW in the room and introduce them to the client, would be a great way to connect with the patient. And again, being clear and consistent with the messaging when introducing the CHW to the client. Now, with delivering MAPS, there was a lot of discussion around MAPS characteristics, for example, the length, the number of sessions, et cetera. And there was a concern for potential burden to clients who, again, already are subject to many social determinants and have a lot of other competing priorities. But again, thinking of the CHW as an added value to the clinic and particularly for delivering MAPS. The stakeholders also talked about the fact that the delivery of MAPS needed to be flexible, both in terms of times and locations. So for example, meeting clients in the community instead of having them come in the clinic was also an important aspect. And coordinating care between the CHW and the team, the stakeholders felt that it would be important to use existing technology platform for communication, particularly using the EHR to providing clear and concise communication of treatment plans, and just having this feedback loop that the CHW could use with the clinic to inform them of the process for the client. And again, MAPS wouldn't be sort of delivered in a vacuum, but really exist in a social and political context, as Dr. Woodward already talked about. And so there was a lot of discussion around the barriers, particularly when it comes to structural racism and discrimination, poverty, et cetera, that could interfere with adherence to ART or antiretroviral therapy. One of the solutions that the stakeholders brought up is, again, having a more diverse workforce within the HIV clinics, and we're hoping to at least delivering on that with the CHW. And the facilitators are listed here and really have to do with linking patients to social services and having norms and respect and dignity for HIV care. So in conclusion, we found that this pre-implementation work helped us to understand that the CHW must be welcome in the local clinic community, and there's a lot of work to be done ahead of time to allowing this integration to be done successfully. Again, because when there is a lack of role clarity, that brings a lot of frustration both on the CHW and the clinic end. And both in terms of, when thinking about health equity issue, obviously we want the patient CHW relationship to be a trusted one where we can address racial disparities in viral suppression, but supporting the CHW is also an equity issue, and making sure that they have the tools and that they're well integrated in the clinic is an important aspect of the pre-implementation work. Again, having the teams be on the same page with the messaging to the patients, and again, framing MAPS as an extra support instead of a burden to the client and the clinic, and using processes that are tailored to promoting efficiency with information sharing, particularly using the EHR and other available methods. And so for this work, we're planning on, we're actually just enrolled our first set of patients last month, and we're engaging in a stepwise trial where the clinics are randomized to one of 3 implementation start times. We're collecting baseline data before the implementation that we'll use to compare after the implementation of MAPS. And so the goal is to also measure the effect of our implementation strategies up to 12 months after delivery of MAPS. And the reason why we decided to use a stepwise trial is for several advantages. One is that the clinics can act as their own controls, allowing estimation of effects from both between and within clinic comparison. And this can help with statistical power. But also because based on our stakeholders engagement, they felt that there would be a fairness issue if one of the clinics fell into the control group. And so the advantage with this method is that all the clinics at the end do get the intervention, even if it's at different times. And also logistically, it's really hard, even with 3 clinics, I just realizing how much logistical work comes with that. And so having us start across 12 clinics would be more challenging. And so it helps us to sort of roll this out on a gradual process. And I'm going to end with this acknowledgement slide of my co-PIs and also my research team and the different institutes that have funded this work. Thank you so much.
Thank you so much once again to our presenters, Dr. Woodward and Dr. Montplaisir, for your time today, and thank you for those in attendance. Now we do have a bit of time for any questions, thoughts, discussions, comments, so feel free to unmute yourself or type those in the chat.
I'll lead off a question if I can, while we're maybe waiting for some others to come in. Both really phenomenal talks, so helpful, both high level, important context, as well as really useful specifics, I think, for folks. Florence, I'm curious to hear, as you were explaining the stepped wedge design to the clinics, sort of what their understanding of it was, what concerns they might have.
Yes, well, the first question was, which cluster am I going to be in? Because a lot of them did not want to be in the last cluster. So that was one of the main concerns. I think the other concern, again, because we're limited with funds, we have to split the CHW across 2 clinics. And the culture in HIV clinics is such that they feel very protective of their data and of the experiences in the clinic. And so there was concern that the CHW would go and share information about different clinics. And we had to, emphasize that this is not something that we would tolerate. We address it in our training, et cetera. But these were the main concerns. And also making sure that there's a good fit. For example, we're working with Mazzoni, who's a large LGBTQ population. They felt very strongly, for example, of having the CHW represent the population that they serve. So they were very sort of specific requests, but around the step wedge, it was really sort of the concern about being on the last step.
Well, and something I added in the chat that I'll just say verbally is, but the stepped wedge is more likely to get people to agree at all versus an RCT when they could potentially be randomized to get nothing. So I don't know how you that conversation, but usually the stepped wedge is such a preferable research study design because everyone will get it.
Yes, I agree. I think that the challenge or the effects of temporal trends. And so with the pandemic, for example, like our baseline data or baseline retention valve suppression data is probably going to look a little funny because of the pandemic. So I think there are some challenges to have to address, but I agree with you. I think it's a very powerful design.
And exactly what you mentioned, one of my roles is as like a facilitator. I'm trained in facilitation, which is an umbrella implementation strategy. But basically, whoever in your projects is like doing the strategies, that implementation practitioner role. And when I have had that working on projects where there is a stepped wedge, it exactly addresses your last point, which is the fact that if you start up 6 sites at once, 10 sites at once, it's not even possible unless you have a bunch of people in those roles. And so it is also just more feasible and with better quality. You can actually do the implementation plan and enact it, or be a better facilitator in my case, more feasibly. And you can also it's a better use of grant money. You can pay fewer facilitators if you spread their work out over time, rather than having a bunch of them that work really intensely at the beginning, but kind of peter off. I hope that continues to work out for you. That's really exciting. And so you said whenever you came on, you were like, we didn't do a lot of the equity things you're recommending. Like we hadn't planned it in, and yet it was so much of a presence in many elements. Like, for example, the fact that the community health workers had to have some matched lived experience with people they were serving. The fact that then you all really were considering throughout, the flow of care, the technicalities in the clinic. You had that visual of like considering the societal context. How did that come to be?
So as part of, ahead of the launch, we actually applied for a supplement. And so we were very intentional around doing this work to inform the rollout of the intervention. Again, it's, I think a lot, because I come particularly from a non-implementation science background. I'm a physician scientist, but focus mostly on HIV work. And I work closely with implementation scientists and have learned to sort of grow in that space. But I really can understand why sometimes interventions fail, right? Like if you don't spend that work thinking of how to integrate, particularly in this setting, the CHW in a way that is empowering for them, right? Like you're gonna have turnover and your intervention is gonna fail. And so I definitely see value in spending that pre-implementation evaluation, ahead of the rollout. And obviously, we're crossing our fingers that it works.
Absolutely. So it sounds like you had just, from your training, kind of had those mindsets, had some of those perspectives. And it sounds like some of your healthcare partners, the systems that because they said that they weren't those the groups that you said insisted the community health workers sort of be a matched lived experience.
Yes, absolutely. And a lot of those solutions actually came from those this qualitative work with the stakeholders.
Which is a great assessment. Oh, I'm excited for you.
Thank you.
I hope that goes. Any other burning questions or kind of issues or comments? Okie dokie. Do you need anything from us?
I don't think so. It was such a pleasure to have you as part of this webinar series, and the presentations were so amazing, and I loved the little interactive elements that you included as well. So thank you both so much for your time and sharing your expertise. Absolutely.
And we were informed that this will be recorded and live on, so you could re-reference if needed. Thanks to everyone here who's doing really important work to make our world a healthier, more just place to be. That's the main goal. That's the main thing. Thank you.
Thank you so much, everyone.
Thank you, everyone. We hope you have a great day.